Our first presentation today is from Dr. Julia Moore, the Senior Director for the Center for Implementation. She has a PhD from Penn State, where she was trained as an implementation scientist, researching the best ways to implement evidence-based programs. Dr. Moore is passionate about supporting professionals in how to use implementation science. She has delivered dozens of workshops to more than 1,500 participants, and her free online mini course enrolled more than 1,000 people in 1 month. Her presentation today is Cutting Edge KT, Adaptations and Sustainability. If you have questions during the presentation, please ask them in the chat box and we will address them as we can. Using questions from the chat box, I will moderate a Q&A following Dr. Moore's presentation. Julia, are you ready to begin?
Yes, I am. Hi, everyone. I am so excited to be here today to start off the conference. So I wanted to share a few quick things about me because I'm going to talk a bit about kind of my cross-border experiences. So I am originally from Canada. I went to University of Alberta and then did my PhD at Penn State. And so I have experience on both the Canadian side and American side and have now returned back to Canada. And I'm going to talk a bit about that, particularly when thinking about some of the components related to adaptations. So today I'm going to talk about adaptations and sustainability, two very cutting edge topics in knowledge translation. But before I dive deep into those, I want to kind of cover a few really basic elements at a high level very quickly to make sure we're kind of all on the same page in thinking about some of these core components. One of the first things we know is that we have a major naming challenge in the field. We call it knowledge translation, implementation science, knowledge mobilization, research to practice. And so we know that the key core piece of this is that we ultimately have a major gap between what we know and what we are doing. In fact, people say that it takes 17 years for research evidence to be used in practice. And we know that we can do better. And so in fact, that intro was all about the fact that we can do better than this. And so how can we narrow that gap by getting research evidence out there in the hands of people so that they use it? I'm going to talk about a specific aspect related to knowledge translation, kind of honing in on some key components. We really see knowledge translation as an umbrella term that encompasses a huge range of activities. It includes both dissemination and implementation. So dissemination is thinking about how we share information, ideally in a bi-directional way, back and forth, to increase people's awareness and knowledge of something. And the act of doing that is called dissemination practice. Ideally, dissemination practice is guided by a science of dissemination. While we know that this is a major activity that is very common, we also know that dissemination alone only produces a pretty small change in outcomes, about 1 to 2%. That's why we often start shifting down this spectrum towards implementation, which is where we use strategies to change people and organization and system behavior to actually get the outcomes we're looking for. The act of doing this is called implementation practice. And ideally, that is guided by implementation science, the study of how best to implement. I'm going to focus today on how we can use implementation science to guide our implementation practice related to two specific areas, adaptations and sustainability. Essentially, we are looking to be more strategic rather than relying on chance as we move forward with implementation, especially the adaptation components of implementation, which are often very reactive rather than strategic and proactive. So the core thing that we need in order to do this is to understand the foundations of what makes implementation science be able to help us in our implementation efforts. And that has to do with using process models, theories, and frameworks. This is really the foundation of how we can apply implementation science in practice. Process models essentially outline steps or stages to put evidence into practice. So they are these models that give us a series of steps or stages, often an iterative steps or stages, that help put that research evidence into practice. Theories help us understand and predict causal mechanisms. So what is it that makes a person change their behavior? And frameworks help explain factors that influence different things. And we are going to refer to some frameworks today in thinking about adaptations and sustainability. In order to be able to think about adaptations especially, we need to understand what it is that we are implementing. So some people get to move forward and implement what we would call an evidence-based program. So a pre-packaged program that is already tested and ready to go and be implemented, that has all of the materials and components already built into it. But the reality is there are a very small number of evidence-based programs compared to what is often happening, which is people have something they want people to do differently, what we would define as the what, but we don't actually know how we're going to change people's behavior so that they'll do that thing differently. Ideally, our what, the thing we want people to do differently, should be based in evidence. And there's a great paper by Brown and colleagues that talks about how the what could include 7 different P's, they called it. So things like programs, practices, procedures, processes, pills, policies, products. And so these 7 P's describe things that we want people, organizations, or systems to do differently. But just because we want them to do them differently doesn't mean they're going to do it differently. Otherwise, dissemination would be more effective at changing people's behavior. But since they're not necessarily going to do what we want them to do automatically, we need strategies to actually change people's behavior. And that's where the how comes in. So the strategies describe how you can change people's behavior. And ideally, those should be based on evidence as well. But not only should we have evidence that the strategies are effective, but they need to be linked together using theory. I think the best example of this that I use all the time as an example is because it's so easy to understand, is the idea of getting a flu vaccine for healthcare workers. So there's lots and lots of evidence to show that all healthcare workers should get a flu vaccine. So that is our what, the thing we want people to do differently. And people often pick strategies like reminders as a way for people to change their behavior. Reminders are, in fact, an effective strategy for changing behavior. But reminders are only going to work effectively if they tap into the underlying reasons that people do or don't change their behavior. Since people don't really have memory as one of the primary barriers to getting a flu shot, reminders are not likely to be very effective in this case. Because some of the key barriers people have are things like time, access to the flu shot, and then beliefs about flu shot that really drive whether or not people want to and are able to get the flu shot. So that's a great example of why we want to pick our strategies to change people's behavior, not only based on the evidence, but also the underlying behavior change theory. There's a huge list of implementation strategies out there. In fact, you can go to what they call the ERIC list by Byron Powell and his colleagues that lists 73 different types of implementation strategies that you can use. And so we want to be really thoughtful about how we pick those. I wanted to share kind of this whole concept up front because as I go through talking about adaptations, it's going to be really important to think about kind of these different components of what makes up the thing that you are implementing when you think about what it is that you are adapting. So that's sort of the first piece that's really, really about what do we know about implementation and what we're implementing, and how can we use that to guide adaptations. So now we can start thinking about adaptations, and in fact, first, the broader concept of implementation quality. And so implementation quality is talking about whether an intervention that includes both that what and that how is implemented the way it was intended. And essentially, we need this in order to create the outcomes that we want. So this is an equation from the National Implementation Research Network, or NIRN, that I think is such a great way to capture in just a few bubbles all of the different pieces we need to be thinking about when we're implementing. The idea behind this equation is that in order to create the outcomes we want, we need to have an evidence-based practice, that's your what. You need implementation strategies that are based in evidence and theory, that's your how. And we need to implement those with high quality, so we need to implement them the way they were intended. And we need a context, context that enables implementation. Here today, I'm gonna focus on implementation quality and how important that is in getting to those significant outcomes. But while I'm only gonna focus really on implementation quality, I wanna note that that is not the only thing that is important. And in fact, when NIRN developed this, they purposely put multiplication signs, because if any single one of these is 0, you are not gonna reach the outcomes that you are looking for. So I'm gonna focus on the green bubble, but we really need to be thinking about all of them as we move forward with implementation. So why is it important to measure implementation quality? Well, research has shown us that measuring implementation quality, just the act of measuring it, actually leads to better implementation quality. And better implementation quality leads to better outcomes. As well, we know that measuring implementation quality helps us unpack the black box of what really happened. So we know that many implementation efforts don't go as we had hoped. And by understanding whether or not something was implemented as intended, we can get a better idea of whether an intervention worked or didn't work because the intervention itself did or didn't work, or whether it was an issue that it wasn't implemented with enough quality to produce the outcomes we were looking for. Also, measuring implementation quality can be a great way to show current funders or potentially future funders what was actually done. I've worked on projects where people used implementation quality data to show that they were implementing an intervention with really high quality and managed to successfully get additional funding to sustain their intervention just because they were able to show that they had implemented it very well. So when we talk about implementation quality, what do we really mean by implementation quality? So implementation quality is made up of multiple different components. So in this paper by Durlach and Dupree, they actually talk about 8 different components of implementation quality. 2 of them are specifically related to having a control or comparison condition in research trials. So I'm not going to focus on those 2, but I'm going to talk about these 6 components. And I've noticed that in some of the chat box, people have been asking about the difference between implementation quality and fidelity. And so I'm about to get right into that right now. So the idea of implementation quality is was this implemented as intended? And that is made up of these 6 different components: dosage, reach, quality of delivery, participant responsiveness, fidelity, and adaptations. So I'm going to go through and describe each of these. We are then going to actually do a little activity together. And then from there, I'm going to go even deeper into talking about fidelity and adaptations. So the first one that we can think about when we think about implementation quality is dosage. So essentially, how much of the innovation or intervention was delivered? So if you had, for example, training sessions, how many training sessions were delivered and how many people attended those training sessions? The dosage is going to look very different based on what your implementation strategies really are, because whatever you intend to implement is truly going to guide what the dosage measures would look like. but it's essentially asking, are people getting what you wanted them to be getting? Next, we have reach. Reach is asking whether the innovation is reaching the target audience. So you could be asking how many people you're reaching and whether those people are really the people you should be targeting or intended to target. So, for example, we see situations all the time where people are trying to implement an intervention. They're having struggles recruiting people to that intervention. And so then they end up in a situation where they end up recruiting people who probably aren't a great fit for the intervention, but they're just trying to fill seats. And so that is an issue of reach. Next, we have quality of delivery. Quality of delivery has to do with the affective quality with which someone is implementing something or delivering something. This is honestly the one that people struggle with the most in my experience when they're talking about implementation quality. But affective quality, or this quality of delivery, is really that feeling you get when you are listening to someone or watching someone and feel as though that person is a really engaging presenter, for example. So if I think back to when I was in undergrad and grad school, I can think of people who were very disengaging presenters. In fact, my first psychology professor in my first year of undergrad was so boring that I dropped out of the second half of psychology and took calculus because I thought psychology was so boring. I have subsequently gone on and spent a massive amount of time doing behavior change theory and psychology related topics. But essentially that person was delivering lectures in such a way that it was so boring, I could not get engaged. And so that quality of delivery is kind of how well someone is able to present the information. And very, very closely related to this idea of quality of delivery is participant responsiveness. So this is kind of the flip side of that, which has to do with how engaged are people in whatever it is that they're attending. Often these two things are related. So when there's higher quality of delivery, people are sometimes more responsive. But that's not always true. And this can also include components like attendance. So are people even showing up to whatever your implementation strategies are? Next, we have fidelity. So fidelity is the aspect of implementation quality that we think about and talk about most often. And it is very important, but I do want to note that it is only one of the aspects of implementation quality. And so I think it's really important to also think about some of those ones I just described before. The idea of fidelity is essentially looking at whether the implementer is closely adhering to what it was they were supposed to do. I, for example, am an absolutely horrendous cook. And so it would not be surprising that I would have cookies that would end up looking like this. Because I pretty much have very poor implementation quality when I am cooking. I don't follow recipes, I don't follow them closely. And then when things don't turn out at the end, it is not surprising because I did not have fidelity to what it was that I was doing. And so we see this all the time when we are implementing interventions. And so we can ask the question of, were people following closely what it was that they were supposed to be doing? The concept of fidelity is often tied very, very closely with the idea of adaptations. The idea of adaptations is that we make changes when we are actually delivering something. So for example, people may add components, delete components, modify components. All of those are adaptations to whatever it is that we are implementing. And so I'll talk in a moment about fidelity and adaptations in a much more detail. But before I do that, I want to jump into a little activity where you will have an opportunity to think about some different examples and whether you think it is an example of dosage, reach, quality of delivery, participant responsiveness, or fidelity/adaptation. So I've actually combined fidelity and adaptation because I think sometimes it's hard to disentangle those when we think about examples. So in this activity, what we are going to have you do is we're going to have you type in the in the chat box your answers to each of the questions. So it's probably going to be a really fast typing situation. I have 7 examples that we will go through. And so literally you just write the one word: dosage, reach, quality of delivery, participant responsiveness, or fidelity and adaptation. And we'll go through all 7 of them back to back. So the first example is: presentations were translated into Spanish and available in Braille. Is this an example of dosage, reach, quality of delivery, participant responsiveness, or fidelity and adaptation? Excellent. It's so interesting because people can see other people's responses. I see lots of people typing in the word reach, but I want to add that that is not typically the first one that people include here. So if you have ideas of another one, people are welcome to type another one in. Perfect. So we got a lot of people saying reach, some people talking about quality of delivery, and then we had some people talking about adaptations. So this is in fact a great example of what people typically talk about as an adaptation. It is a good adaptation to do this. And so sometimes we have these negative connotations related to adaptations, which I'll talk about in a minute. But this is in fact an adaptation, and it is a good adaptation to do. It is an excellent idea to translate components of your intervention or all of the intervention into different languages. And the reason you are doing this adaptation is often to enhance the reach of what it is that you're doing. So it's sort of an adaptation with the goal of enhancing reach. So for all those people who wrote reach, I can definitely see that link right there. I want to note with quality of delivery is the way in which someone is able to actually present the information. So the act of translating it doesn't actually tell us anything about the quality of delivery. It just tells us whether or not it was translated. But kind of that implementer enthusiasm and their clarity and they're able to articulate things, those are the components that make up the quality of delivery. Example number 2. Participants signed onto the webinars as required, but they tuned out and didn't pay attention. So is this an example of dosage, reach, quality of delivery, participant responsiveness, or fidelity and adaptation? Wonderful. So we're seeing lots and lots of people talking about participant responsiveness. That was by far the most common response. And I would say that that is definitely the place I would map this one to. But there was a bunch of people who also commented on quality of delivery. And I really like Matthew Hill's comment there, that it's responsiveness and potentially related to quality of delivery if the presenter is not effective. So that might be the case and we don't necessarily know, but that's probably something we want to check into if people are not paying attention. We want to look at what is the quality of delivery in this situation. The third example, training was designed for physicians, but delivered to nurses and allied health professionals. Is this an example of dosage, reach, quality of delivery, participant responsiveness, fidelity, and adaptation? Wonderful. So lots and lots of people, I would say this was a very excellent response here. Pretty much everyone captured that this has to do with reach because we are changing the target audience. So that is affecting the reach of the intervention, which essentially could also be considered an adaptation because we have adapted who we are delivering the intervention to. So lots of people said reach, and then lots of people then added adaptation as well. So amazing job on that one. Number 4, members of the implementation team only attended 3 of the 6 learning sessions. Is this an example of dosage, reach, quality of delivery, participant responsiveness, or fidelity and adaptation? Excellent. So lots and lots of dosage right up front, and then a few more diverse responses getting into some of the participant responsiveness. So exactly, this is really a question of dosage and in fact, potentially also participant responsiveness. I would say both of those map beautifully onto this. Dosage because we're only getting 3 of the 6, so that's having to do with how much. And participant responsiveness because that includes this attendance component. And so this is a matter of attendance related to that. So dosage and participant responsiveness. Number 5, one of the long-term care homes didn't like the way the program presented harms and benefits. So they removed that section. Is this an example of dosage, reach, quality of delivery, participant responsiveness, or adaptation/fidelity? Wonderful. So it looks like everyone here is seeing this as an adaptation fidelity issue. So this is a really, really, really common situation that we see. People go to implement an intervention and they don't like certain components of the intervention and they just remove those components. And in a moment, I'll talk about some of the pros and cons of what happens if we just remove sections of an intervention. So this is a great example of fidelity adaptation. Number 6, the topic was interesting, but the presentation was very boring. Is it an example of dosage, reach, quality of delivery, participant responsiveness, or fidelity and adaptation? Wonderful. So lots and lots of people saw this as quality of delivery. So I would definitely see this as a classic example of quality of delivery. The presentation is boring because the person is not a very good presenter, even if the topic is actually interesting to people. So that is an issue of quality of delivery. So our very final one, number 7, so this is our last activity today, is originally reminders were supposed to be updated every 3 months, but the implementation team decided that was too much work and they did it annually. Amazing. So a little shout out to people like Emma and Ashley C, who saw that this is both potentially an issue of fidelity adaptation, which almost everyone got that one. And the fidelity adaptation is also potentially related to dosage because of how much of the intervention they were delivering. In this case, reminders. And so I use this example because I think it's such a great example to illustrate another very, very common kind of adaptation we see. So reminders are a pretty common implementation strategy that's used regularly. And people often don't like updating reminders because it's a lot of work. Except that the research shows that reminders are effective when they are changed regularly. And so if a reminder stays stagnant and only is updated annually, essentially it fades into the background and is no longer something we even notice, which means that even though reminders are effective, reminders that don't change for an entire year are in fact not very effective at changing behavior. And so it's such a great example of an adaptation that is not a good adaptation for us to be making because it can really affect the effectiveness of that intervention. So I want to say a huge, huge thank you for the participant responsiveness. You had excellent participant responsiveness in this little activity. I wasn't sure how it would go, but I want to say a major thank you to everyone in the chat box. And so now the chat box will return to being regular questions. So please ask any questions as I go through and we'll take questions at the end. So I want to dig a little bit deeper into what we know about fidelity and adaptation, because this is a very hot topic, a very contentious debate that is going on kind of right now. So as I mentioned before, fidelity is often related to kind of, are people doing it the way it was supposed to be delivered? Are they delivering it the way it was supposed to be? Whereas adaptation is seen as changes to whatever they are delivering. So I want to share my own personal history with fidelity and adaptation because it kind of has led me to be very passionate about understanding what is happening in this space. So as I mentioned at the beginning, I'm Canadian, but I did my PhD at Penn State. And while I was there, I worked at a center that was supporting the implementation of evidence-based programs across the state. And people at the time were talking heavily about the importance of fidelity and how we needed fidelity to the intervention at all costs. That was really the language, the message that we were getting over and over and over again from every aspect. Then I returned to Canada, and essentially the message I was getting in Canada was very, very different. And it said, we need to adapt things. We need to adapt things to the local context. We need to adapt to different populations. And pretty much, if you don't adapt, we're not even going to let you walk into the room and have a conversation about implementation with us. And as someone trained as a researcher, I really, really struggled with this. And what was even crazier to me is all their positions were backed by data. So in the United States, people had all these studies that showed that better fidelity led to better outcomes. This is not real data, but essentially they had curves that showed this over and over again, that better fidelity led to better outcomes, and therefore we needed fidelity to the intervention. But in Canada, we had a different situation where people kept citing this Baker systematic review that showed that people who had a higher level of what they called tailoring, essentially more adaptations, had better outcomes than people who had less adaptations. And honestly, for a couple of years, I really struggled to reconcile all of this information. How could we have one situation where people are saying better fidelity gives you better outcomes, and other people saying, well, more adaptations give you better outcomes? How could both of these be true? So as a good researcher, I went and dug deep into the data. I went and looked at the confidence intervals in the Baker systematic review. And that is when I discovered something so interesting. Essentially, it showed that if you had a lot of adaptations, there was, in fact, the potential to have much better outcomes. And that's where this line goes up towards the 4. It's saying, look, this intervention can be even more effective if you make adaptations. But there is also a risk because it can drop below and make it that the intervention is no longer effective at all. Meanwhile, if you make very few adaptations, you're pretty much going to get the same results that they got the first time. And so this was so interesting because it really helped reconcile this idea that better fidelity can in fact lead to better outcomes, but adaptations are not inherently bad and they're not inherently good. We need to understand more about the adaptations to understand whether or not they're going to potentially have a positive or negative impact on the outcomes we're looking for. And so that's when I'm going to introduce now a bunch of brand new pieces of literature and frameworks out there that really help us think about adaptations in a different way so that you can go, if you want to think about adaptations, and dig even deeper. The first one is Sturman and her colleagues, who wrote, in fact, some of the work, the kind of pioneering work on adaptations back in 2003, just came out with a brand new framework called FRAME that they call is an expanded framework talking about reporting adaptations. So it's less about how to proactively plan for adaptations, but more about saying, what was the process you used to make those adaptations? And what was the reason that you had for making those adaptations? And so essentially they help you think about things like, what is it that is being adapted? Are you adapting the context in which something is being implemented? Are you adapting the content that is being implemented? Are you adapting the people that you are targeting? And it asks questions like, when are these adaptations made? Are you making adaptations proactively before you start implementing or reactively after you've started implementing? And in fact, there is some research that shows that if you are proactive about your adaptations, there's a better chance that those adaptations are pretty much a good thing to do. That's not always true, but it's more likely, and that the reactive adaptations are more likely to be potentially detrimental. I want to note that all proactive adaptations are not good things to do, and all reactive adaptations are not bad things to do, and you are never going to be able to prevent all reactive adaptations, because the reality is that we need to adapt when we're actually implementing things. But this helps us think about what kinds of adaptations they were and when they were made. We can also think about things like why an adaptation is made. Is it made to adapt to a new context? Or is it made because of people's underlying philosophical beliefs? So great examples that I have seen related to this is we've done some work in low and middle income countries. And we were in a situation where they were using a drug that was supposed to be for women who experienced postpartum hemorrhage, and it was supposed to help deal with this situation. So women essentially who are bleeding out after they've delivered a baby. But the drug can also be used for abortions. And so there were certain countries that did not want to introduce this drug and literally did not have access to the drug in the entire country because of underlying philosophical beliefs that they had And so we had to adapt based on this philosophical perspective because they would not allow this drug, which was kind of considered what they call first-line therapy. So the best thing to do in this situation. But there's lots of other situations, and in fact, much more common, that we adapt because of the setting in which we're implementing. Maybe the population is a little bit different. Maybe the kind of organization is a little bit different. Maybe the country is different. And so we need to make adaptations for those reasons. And so understanding why we're making them can really help us as well. But that was really telling us about how do you understand adaptations once they've happened. But we also want to be thinking about, do you really want to be making this adaptation? Is that in fact a good idea? And so this is a framework that's being developed by Alexis Kirk and some of her colleagues down in North Carolina, and that I've had the privilege of getting to help with. And they are really asking questions to help set people up to figure out whether they should move forward with an adaptation or potentially abandon or redesign the adaptation in a different way. So they have a whole process of asking a bunch of questions. For example, is this adaptation systematic? And is it designed to really move forward and figure out how we can implement this intervention better? If the answer is yes, then we ask more questions. If the answer is no, this is not really a systematic adaptation, then we might want to discuss the pros and cons with the stakeholders before we move forward. If it is done systematically, we can start asking other questions like, is there going to be a negative impact on outcomes if we make this adaptation? If the answer is no, it was done systematically and there's no negative impact, then that's probably a good adaptation to move forward with. But if it is going to have a negative impact on outcomes, we can start asking questions like whether or not there's a way to mitigate that impact by doing some other strategies. If we are able to do that, then let's move forward. And if not, let's discuss pros and cons. By taking a framework like this, we address the reality that adaptations are inevitable. There are always going to be adaptations in implementation work. We're never going to be able to lose that. And so let's be more thoughtful about them before we start implementing. And it helps us really think about the impact of those adaptations. So it helps us think about whether or not there are changes to things like the core components of an intervention. And so in fact, related to cutting edge things, since I even developed these slides, there's been a great conversation happening at the Society for Implementation Research Collaboration, or the CIRC conference that was in Seattle just last month, where people were talking a lot about how we need to abandon the idea of core components in exchange for core functions. So really asking whether an adaptation taps into the function we are trying to address. So is this tapping into or changing the function of an implementation strategy? So kind of historically, we call them core components, and there's kind of this shift towards talking about functions, which really get back to this mechanism of change piece. Because this idea of whether something is a core component or not is pretty challenging to understand, I like to use a house analogy. Essentially, if you think of your intervention as being a house, what we're saying is, if you make changes to what we would call the surface structure, that is a good thing to do. For example, if you want to repaint your house, if you want to change the doors, if you want to put in new cabinets, those are excellent, excellent adaptations because they're going to make your house look the way you want your house to look so that it will be more inviting. You can get more people to show up, more people to stick around. But you do not want to be going in and bashing down walls and breaking down walls if you don't know whether or not those walls are holding up the structure of the house. And so we want to be leaving the house structurally intact, but making it look the way that we want it to look so that it is more inviting to people. And so we want to be doing the same thing with our interventions. We want to be changing the things that kind of like are the outside paint, but we do not want to be changing those core components or those structural walls inside of our intervention. There's another great resource that I wanted to share that I really, really like the idea of that has to do with balancing fidelity and adaptations. And this one comes from the Cancer Control Group at the National Cancer Institute in the US, where they talk about how we can think about adaptations based on whether they should be a green light, so go ahead. So all of those repainting adaptations are green light adaptations. Go ahead and repaint the walls. There's red light adaptations where we have definitely torn down structural components and we should not move forward with those. And there's yellow light adaptations, so ones that probably land somewhere in between. And so by thinking about these and thinking about them proactively, we can set ourselves up for a greater likelihood of success. So those are some of the key things I wanted to say about adaptations, and I wanted to share some big resources on adaptations. And I do want to note, I know people have been asking about the slides. All of these slides are available, so you can go and look for those different resources on your own. But I wanted to end by talking really quickly about sustainability and how we can plan for sustainability and sharing a couple of sustainability resources with you as well. So why do we need to sustain interventions? Well, we know that we put a massive amount of time and resources into implementing interventions, but those interventions are rarely sustained. And so essentially we are wasting time and money when we do not sustain what it is that we're implementing. And I also think there's this huge risk that if we walk into an organization or community and we implement something and it is not sustained, the likelihood they are going to invite us back decreases. So when we think about sustainability, one of the things that's really important is to recognize and go back to really, really understanding what it is you're implementing so that you can use that to guide how you think about and talk about sustainability. So remember early on, I talked about how we have the what it is you want people to do differently, and how, the strategies we use to change people's behavior. We need to think about both of these components when we think about sustainability. In fact, these are two of the 4 components that we can think about when we define what we're going to sustain. So when you think about sustainability, you can really think about sustainability for these 4 different aspects of your intervention. Essentially, are you sustaining the evidence-based practice, the what? Are you sustaining so that people continue to change their behavior in the way that you want them to change their behavior? You can think about sustainability related to the strategies you are using. So the reminders, education, using champions, communities of practice. How are you going to sustain the use of those strategies? You can think about how you are going to sustain outcomes, and especially measuring those outcomes, because we often do a good job of measuring during the implementation phase so that we know whether or not we're achieving the outcomes we want. But during sustainability, we stop measuring those outcomes. We often stop using implementation strategies, but we hope and expect that people will continue to change their behavior. We also need to recognize that sustainability is dynamic. And so there's some great papers talking about the dynamic nature of sustainability and how we need to consider the fact that there are going to be adaptations happening at all 3 levels over time. The what that you want people to do differently is probably going to change over time. The strategies you use are definitely going to change over time. And how you measure your outcomes is going to change over time. And so our whole conversation about adaptations is closely linked with sustainability, because we can think about what is it that we're sustaining and what kinds of adaptations are we going to need to make during sustainability phase. And with that, it helps us come up with a sustainability plan. And so when developing a sustainability plan, you can think about 5 key things. First, defining what it is that you are sustaining. This is a very, very commonly skipped step and is so essential for setting you up for sustainability success. Second, you can decide who needs to be involved with sustainability. Third, you can understand the context for sustainability. So where is it that you are implementing this? Fourth, you can think about what strategies you're going to use in the sustainability phase. So how. And finally, coming up with an ongoing monitoring plan for your evaluation. So 5 key things to think about. And with that, we can think about the different sustainability tools that you might want to use to plan for and assess sustainability. So to my knowledge, there are 3 great sustainability tools out there that are commonly used in KT. The Program Sustainability Assessment Tool, which works really well if you have an evidence-based program, particularly implemented in a community setting. The NHS Sustainability Model, which works really well in healthcare if you want quantitative data. And the Long-Term Success Tool, which works really well in healthcare as well as other settings and has more of a qualitative conversational feel to it, but tracking data over time. So if you are looking for a sustainability tool, I highly recommend going through these 3 things. And so that's my very, very quick high-level overview of some of the cutting-edge stuff that we know about in adaptations and sustainability. And so I just wanted to end with a couple of quick things. The first is that if you want to know more about any of these topics, we currently have a free mini course that is available until November 11th. And so then it is closing down. And so we have 2,900 people who want to learn about kind of the basics of implementation science. So you're welcome to sign up and join that. And today, this morning, we launched our first full course, Designing for Implementation, that delves even deeper into all of these topics. And you can check us out on all of these things. We have just joined Twitter, so I'm very excited to connect with lots of people there, and we have all of our other information there as well. And with that, I believe that we are going to open it up to questions.
Thank you very much, Julia. That was a fantastic presentation, and we are going to open it up to questions. But first, I wanted to introduce today's reactors and invite them and Julia to switch on their webcams at this time. To introduce our reactors, our first reactor today is Rosamine Ismail. She is a PhD candidate with Health and Health Services Research in the Department of Community Health Sciences at the University of Calgary. Her PhD thesis is focused on understanding the relationship between knowledge translation and health technology reassessment. In addition to her PhD studies, Rosamine is an adjunct lecturer with the Department of Oncology, Faculty of Medicine, University of Calgary. She also works as a provincial trauma epidemiologist with Trauma Services Alberta Health Services. She brings a broad base of experiences and interests in healthcare to her role, with an application of evidence-based research and knowledge translation to clinical practice. Next on our list of reactors, we have Dr. Mary Goldberg, who is an associate professor at the University of Pittsburgh, Human Engineering Research Laboratories, and Department of Rehabilitation Science and Technology. In these roles, she focuses on developing and testing evidence-based continuing education interventions for rehabilitation professionals. She currently teaches 4 courses at the University of Pittsburgh and Coursera on disability, rehabilitation, and assistive technology topics. Dr. Goldberg also serves as co-director on the Neidler Initiative to mobilize partnerships for successful assistive technology translation center and International Society of Wheelchair Professionals. Dr. Goldberg develops unique educational interventions to increase capacity of researchers worldwide to translate assistive technology products. And last but not least, Dr. Megan Tracy is a senior scientist with expertise in both early childhood and lifespan development. Her research has been committed to improving the health of persons with disabilities. She is currently a research associate professor at RTC Rural, the Rural Institute for Inclusive Communities at the University of Montana. So welcome to all of our reactors. And Julia, if you can turn on your webcam as well, we can go ahead and get started. I'd like to thank everyone for participating in the chat and asking some very great questions, and I encourage you to please do so as we move through this conversation. So Our first question comes from Shanti Amaratunga, and I apologize if I'm mispronouncing your name, a pediatrician and public health physician and research professor at the University of Auckland in New Zealand. And Shanti asks, is there a reference to the brown paper just referred to? And that's to you, Julia, and this is referring to the brown paper on slide 9 of your presentation.
Yes, I will. The moment this presentation finishes, I will add it to the chat box and I will send out that paper.
Great. And this next question is from Heidi Decker-Maurer. She's a KT specialist for the Stout Vocational Rehabilitation Institute in Wisconsin. This one is also for you, Julia. If dissemination is only 1 to 2% in terms of uptake, what percentage is implementation?
Oh, sorry, I should have added that. And often I like asking people. Unfortunately, it is about 7 to 10% change in outcomes. So it doesn't mean change in behavior, but change in outcomes is about 7 to 10%.
Great. And so our next question I'm going to direct to Megan Tracy. From a NIDLR grantee's perspective, what are some common barriers to sustainability that you've encountered, and how have you responded to those barriers?
I would say that a lot of our work that has focused on improving health with people with disabilities is bridging the shared outcomes from your non-traditional public health partners, centers for independent living, developmental disability service providers, to the outcomes of your more traditional partners. That takes time. And I would say that creating that interdisciplinary team that understands one another's assets, the inputs to the evidence-based program and how it's implemented is something that we have to really pay attention to in building sustainable programs that really are consumer-driven, are constantly following the processes that assure that the responsivity is there, that the quality is there, the fidelity is there. All of that happens on site within some of these non-traditional partners' facilities, or somewhere in the community, but led by those partners, and need to meet some of the fidelity criteria of more traditional public health and healthcare providers. So it does take time to bring those two together. And I would say the other part is really underscoring the importance of self-determination and choice in terms of helping that traditional public health healthcare partner understand that that is the driving value of the disability community, and that it's not necessarily a threat to fidelity, but it should strengthen the commitment of the disability community, the reach, and the responsivity to the intervention if we really do protect it in that way.
Great, well, thank you so much. And this next question actually comes from our center's project director, Dr. Kathleen Murphy, and she asks, and this one is for you, Julia, has anyone set up these implementation components in a model of theory of change, illustrating about how some are likely contingent upon others, i.e. engagement as an outcome of quality and adaptation?
So not directly to no. So at this moment in time, no, but I would say that Shannon Wiltsey-Sermon's new paper starts to do some of those pieces, but it does not set that up in a model. I think that Alexis Kirk's work starts to push that as well. And in fact, I know that the two of them are talking about collaborating to even move some of that agenda forward. So I think that we are going to that place. And I also think there's a new grant that's really looking at mechanisms of change that hopefully will start to push that forward as well. But as of today, right now, I do not know of anything that has mapped out those different components. And a small plug that the Durlach and Dupree paper that I used to describe those 6 different components that originally has 8, I would say is an underutilized way to think about these things. So if you want to think about adaptations, I would highly recommend reading page 329. It's a long, intense paper, but page 329 is kind of a golden nugget in that.
Great, thank you. And Julia, would you mind in the chat box just spelling out some of those names and resources that you just, thank you so much. And so then I'll turn the conversation over to Dr. Goldberg. What advice do you have for someone who is struggling to generate participant responsiveness? What strategies have you used in your work to generate participant responsiveness?
Thank you. This was actually one of the notes that I had after reviewing Julia's slides or Dr. Moore's slides initially. It reminds me a lot of strategies I've learned to implement related to online learning and how that has actually helped me be a better instructor in the live classroom as well. So making sure that participants feel some ownership and connection to the community is huge. And so we've learned that if a learner is disengaged because they don't feel that they're part of the community, their long-term learning outcomes are going to be lower. And so one of the engagement strategies that we have used is to have participants introduce themselves at the beginning and connect on a personal level with both the instructor and the other learners, and to continuously engage with the participants so they don't feel like they are floating out there in cyberspace. And so I've started to do a lot of connecting in my in-person classes at the beginning of each session to make sure that participants are not only engaged with the content, but also engaged with the other learners to make sure that we keep that sense of community consistent.
I apologize. Thank you so much. And this next question comes from one of our reactors, from Rosemine Ismail, and this is for you, Julia. And I apologize, here we are. She asks, sometimes we may not know if adaptations lead to a negative outcome or unintended consequences until we try them. How do you deal with that?
Yes, I mean, I think that is the reality. We rarely know. And in fact, I think that, we are trying to be proactive, but the reality is a lot of these things we only really know after the fact. And so I would say the most important thing is, one, having early conversations about what these adaptations are, having repeated conversations over time, and then actually tracking that data. Because I get parachuted into projects when people have not been successful very, very, very often. But essentially they have no understanding of what they actually implemented and what that implementation quality is. And so if you don't have any data at all to tell people how well something was or wasn't implemented, then we have no idea why it didn't work. So I think the key is collecting data along that pathway so that you can always go back afterwards, particularly if you're planning to spread and scale something.
Thank you so much. And another question for you, Julia, and this one comes from Matthew Hill. He's a Master's of Public Health student at Central Michigan University and a Cochrane Systematic Review author and KT specialist. He asks, have you done any work with Cochrane Knowledge Translation?
I have not.
Okay, well, thank you. And then our next question, I'll turn it over to Rosemine Ismail. So Rosemine, Julia covered fidelity and adaptations to content as a component of implementation quality. In your work, how have you balanced the needs to tailor KT strategies to a context and the need to be faithful to the core components of the strategies?
That's a great question, Donna, and quite complicated to answer in the next few minutes. But I think one of the things I mentioned in the chat was around the TIDER checklist. I don't know if people know about it, but it stands for Template for Intervention, Description, and Replication. And it's a checklist that's available that really helps you kind of describe your intervention in detail. And Julia talked about this as, really, it has to be really, really explicit as to what you're doing, how you're doing it, where you're doing it, and that's what this checklist goes into is some of those details. So I think as part and parcel of trying to implement interventions within a clinical setting, it's really, really important to be explicit around what you're doing and how you're adapting it, and as Julia said, to collect that data so that you can go back and see, what did we do? What did we learn? What did we do differently? Rather than, as somebody mentioned in the chat box, being a black box. I don't know if Julia wants to comment more on that.
Yeah, I completely agree, Rosemond, with everything you just said there.
Thank you. And actually, that's a very good segue. Another question from Heidi Decker-Maurer. She's asking, what's the black box we're unpacking? And Julia, if you could address that a little bit more.
That's a great question. I think that So first I should say the reality is we're probably unpacking a lot of different black boxes at the same time. That's because typically we're implementing things. So it's pretty common that we are implementing something where the what is not actually crystal clear. So we might have to unpack the black box to understand what it is we truly want people to do differently, particularly in situations when we have broad concepts. So, when people talk about things like patient-centered care, that's a very broad concept. And so that what is essentially a big black box that needs to be unpacked. We can also unpack the black box of the implementation strategies, what they are, whether there's evidence for them, and whether they are linked back to the underlying what using behavior change theory. And we can unpack a black box of what did people actually deliver? So what was the implementation quality of those two different components when they moved forward with doing it? So I think there's probably several different black boxes that we are really unpacking because typically we implement things and kind of hope they work and have a little bit of evidence for components of them, but we don't totally know. And so I think, yeah.
And Julia, this is Meg Tracy, can you just expand on the who? Because traditionally I think about the black box as the organism and what it brings to that response system.
Yeah. So do you mean who in terms of who it is that we want to change?
What the individual and the range of individual differences brings to the evidence-based.
Yeah, absolutely. And so we know that we are often asking, even for organization or community level interventions, we need individual people to actually change their behavior. And those individual people are different from each other, and how they're going to interact with the intervention is going to vary. And so I spend a lot of time thinking about and working on things like motivation and how people have different drivers of motivation. And so how that affects how successful an intervention is going to be. So there's a lot of different factors that kind of interact in that space. Great comment, Meg.
Thank you so much. And this question comes from Susan Lin, an occupational therapy professor. I've seen studies where they adapted the intervention and expected the outcomes to be less effective, but they were effective. What are your thoughts about this, Julia? Could it be that adaptation didn't alter a core function of the intervention?
Yes. So I would say two things, Susan. Great question. Great job noticing that, because that definitely is happening. And so I would say that what it means is it's not changing a core function. And I think there's also situations where adaptations help embed things within organizational structures that actually set them up to integrate that work even better with the way that people are already functioning and set it up for better sustainability. So a great example, I was working on a project years ago that was looking at mobilization in older adults in hospitals. And they embedded that with a provincial strategy that was about senior-friendly communities. And so by embedding these components together, they made some adaptations, but I think they ultimately strengthened the intervention by making it part of this larger whole that had a huge policy, higher level push to it. So I think that's a perfect example of why adaptations aren't good or bad. We need to understand what the adaptations are.
Thank you. And we have a few more minutes, maybe time for one or two more questions. So I will pose another question to Mary Goldberg. What recommendations do you have to improve the quality of delivery? And how have you adapted the method of delivery to best fit your target audience's needs?
Sorry, I'm unmuted now myself. This is a great question. We do a lot of work in less resource settings also. I'm thinking specifically of some of the training we do for wheelchair service providers in Latin America. And we have developed some full online courses, but we've modeled those after a standard training package that has been produced by the World Health Organization for in-person delivery. And we have found through a variety of pilot and feasibility studies that a hybrid approach works best. And we've developed some instructional manuals and components to work with our implementing partners to make sure that they're not changing any of those core structural components, to make sure that these training packages are still implemented as originally designed, so that they still have that high fidelity. But the early conversations with our stakeholders are completely critical to making sure that that goes off without a hitch. So sort of the nothing about us without us philosophy, right? Of making sure that they're engaged from the get-go. And that's really helped with that, alongside this instructional manual component has really helped with the quality of delivery, but still allowing us to make adaptations. So thanks for the question, allowing me to participate.
I'm sorry, just a final question to close out this session. And this last question is for you, Julia. And this question comes from Heidi Decker-Maurer, and she's asking, is implementation quality similar to Fidelity?
So I would say that implementation quality is a broader construct, and that Fidelity is a component of the larger implementation quality. So they're kind of related to each other, but one is a bigger piece or a smaller piece to this bigger puzzle.
Great. Well, thank you so much. Again, thanks again to Dr. Moore for a fantastic presentation, and to our reactors for participating in the discussion.
Thanks so much, everyone.